blood transfusion. It is a transfusion of large. Well, actually, I didn't found this in the notes that I'm studying about.
That's fine. You can watch the video later on. So massive blood transfusion is basically transfusion of full blood volume to an adult, in 24 hours, or half of blood volume in an adult in 4 hours. Okay. In a child, it's transfusion of more than 40 milli per kg per hour. All right. So you need to differentiate into adults and the children. So adults, more than 1 blood volume in 24 hours, or more than 50% of blood volume in 4 hours. In children, transfusion of more than 40 milligram per kg blood volume per hour. All right. So what are the complications of massive blood transfusion, Azir?
Sorry, I can't hear the question.
Complications of massive blood transfusion.
Yeah, the complications. There may be a hemoconcentration, and there is iron deposition or hemosidrosis.
It's fine. So I think this is the short answer is this is the wrong answer what you said. So you probably need to reread it. So complications of massive blood transfusion are many things. You're giving your patient lots of blood with different body temp with different temperature. Hypothermia, coagulopathy is one of the highest risk of complication. You're giving them loads of fluid, so fluid overload and another one. So the main three things that you need to mention. So think about it. You're giving your patient lots of blood volume with different temperature. So the risk will be fluid overload, hypothermia, and coagulopathy. All right. The giving your patient RBCs, the RBCs usually do not have any platelets in them. So thrombocytopenia is another risk factor. And you have electrolyte imbalance and adult respiratory distress syndrome, which we just mentioned. Okay. So fluid overload, hypothermia, and coagulopathy, and thrombocytopenia, electrolyte imbalance, and adult respiratory distress syndrome. Okay, the electrolyte imbalance or disturbances are mainly hyperkalemia, increase in the potassium level due to leakage from the stored RBCs. Okay.
Okay.
Well, did we do with breast cancer last time?
Yes.
Yeah, I think we did. So shall we do this
Yes.
one?
CA esophagus.
Well, we haven't done esophagus. So you have a Nazir. I'll give you another scenario. That was a very short one. So you have a smoker, a male smoker. He has background of gastroesophageal reflux disease and presented to you with weight loss and dysphagia. Okay. Can you tell me what is the lining of the esophagus?
The lining of esophagus is non-keratinized stratified squamous epithelium.
Okay. What is your most likely diagnosis from this presentation?
It's most probably will be a cancer esophagus.
Can you specify?
I don't know. Squamous. Do you mean it's squamous cell carcinoma of the esophagus?
I think it's adenocarcinoma instead. So
adenocarcinoma of Barrett's esophagus.
Yeah. Before we proceed, can I just ask, did we do this as well?
Sorry?
Did we do the cancer esophagus one as well last time?
No. We did. I think we did the only breast cancer.
No, sir.
Okay. We didn't. All right. So can you tell me the causes of cancer esophagus in this patient?
This patient, I think the smoking and the chronic gastroesophageal reflux disease.
Yeah, so these are the two main risk factors. So he's a smoker and the chronic gastroesophageal reflux disease, so he might be having Barrett's esophagus. What's the best test to do to confirm your diagnosis?
The best test is endoscopy with esophageal ultrasound and biopsy.
Okay, excellent. So when you're being asked about cancer, so there is different things that you need to know in the question. So there is one, what is the best test to do, and what is the first test to do? Okay, so the best test to do in this patient is always biopsy with, biopsy and histology or pathology. Okay, but the first test to do might be a little bit different. You might need to do bloods, you might need to do a CT scan or CT cap or things like that for grading and staging. But best test is the confirmatory test. Okay. What are the useful information that a biopsy can provide to you?
Useful information. It will give me a type about the grade of the tumor, and that there is the surgical margins, there is margins, invasions, lymph nodes.
Yeah. So I mean, the short answer here is grading and immunohistochemistry. But I would agree with you too. You can classify it into the gross pathology, like what I did last time, and the
Yeah,
microscopic pathology. Yeah, it can tell you about the shape of the tumor and the site of the tumor and the types of the tumor. Is there any necrosis? Is there any lymph node metastasis or not? And the depth of invasion as well. That's by growth pathology. Two, you can do by the microscopic pathology. You can know more about the type of the cancer, whether it's an adenocarcinoma or a squamous cell carcinoma. And you can know about the degree of differentiation and anaplasia. And finally, you can do immunohistochemistry for presence of any cells or anything like that. All right? Or antigens. What is the type of the stain used in immunohistochemistry?
Cytokeratin.
Cytokeratin, excellent. Pathology report showed Barrett's esophagus. Are you able to define Barrett's esophagus?
Yeah, by esophagus, it is columnar metaplasia of the stratified squamous epithelium of the esophagus.
Okay, so yeah, so it's basic, yeah, columnar metaplasia of stratified squamous epithelium at the lower end of the esophagus. It happens due to chronic irritation of gastroesophageal disease and high risk of cancer, and will require screening over time. So, what is the staging of the esophagus?
The staging of the esophagus, it is a T and M staging. So
Yeah.
T, tumor, there's TIS, which is carcinoma in situ, high grade dysplasia. T1, which is tumor invading the lamina propria, muscularis mucosa or mucosa. T2, it will invasion into the muscularis musculosa. T3, it is invasion into the adventitia. T4, there is T4A and B. A, it invades the resectable structures, while T4B invades the unresectable structures.
Okay, well done. And N and M, you can just, yeah, it's fine. You can just say it later on. Great. So the patient had pleural effusion. Can you find, I mean, in this particular patient, what would be your most likely diagnosis with pleural effusion?
Yes, number one, it's due to the spread of the cancer cells to the pleura. Also, maybe due to the obstruction of the thoracic duct, and maybe metastasis to the lung.
Okay, excellent. So the causes will be, like you said, the three causes: spread to the cancer pleura, and metastasis to the lung, and the obstruction of the thoracic duct. Is there any pathological test that you can do to confirm a diagnosis?
Yes, cytology from the pleural effusion.
So yeah, you're gonna do aspiration and send it for cytology, right? What is the treatment for that?
There is a thoracocentesis and there is a pleurodesis, also indwelling pleural catheter and pleuroperitoneal shunts.
Yeah, yeah. So I think the treatment would be mainly palliative. I'm not really sure if pleurodesis is something that they still do, but I would say thoracocentesis and palliative treatment and indwelling catheter will be the treatment. I know that pleurodesis and the shunting is there, but to be honest, I'm not really convinced that pleurodesis is something that they still do. And also the shunting, you're basically shunting the cancerous cells to a different area of the body. So I'm not really sure if this is the correct answer. So I'll just say the palliative thoracocentesis and the indwelling pleural catheter. Okay. The patient had a swelling in the left over the left clavicle. What is your most likely cause for that swelling?
It will be most probably a left supraclavicular lymph node.
Yeah. What do you call it? It has a name. Do you know its name? The Virchow's lymph node. Virchow lymph node. Yeah. Investigation that you can do.
I will go for fine needle aspiration cytology.
Yeah. and you can do excision and biopsy as well. The microscopic feature that you're most likely to find.
Metastatic adenocarcinoma.
Yeah, so now, and you said adenocarcinoma, that's the correct answer, not squamous cell carcinoma.
Yeah.
Because the patient had gastroesophageal disease, and this increased the risk of adenocarcinoma and not squamous cell carcinoma. Well done, Azir, thank you. So in terms of summary, just a quick summary, you have an old patient with history for smoking and dysphagia and weight loss. The main thing that you need to think about here is esophageal cancer, specifically adenocarcinoma if they have GERD, gastroesophageal reflux disease, or squamous cell carcinoma if they are of Asian descent and eat spicy food. Okay, so Barrett's esophagus will predispose adenocarcinoma, and the best investigation to do is endoscopy and biopsy for two things: to grade the tumor and to do immunohistochemistry. The complications of this esophageal cancer are: it might be to the lung, it might lead to pleural effusion, and the best test to do is aspiration and send it for cytology. All right. And also, if they develop supraclavicular lymph node swelling, you need to do fine needle aspiration cytology to look for the adenocarcinoma cells inside it. Okay, the treatment usually for the pleural effusion is palliation and thoracocentesis. Mainly those two are the treatment, or you can add an indwelling catheter as well. Great. Who's next?
Yes, it's me, Dr. Sam.
Okay, great. Okay. So do you have a middle-aged man presented with right inferior fossa pain? The surgery was done and revealed that they have dilated appendix that looks like a mass. The histology revealed appendicular abscess plus 6 millimeter, centimeter appendicular mass involving the mucosa and muscularis layer. Can you define an abscess and what is inside it?
Abscess is pus, that is dead, dying tissue, neutrophils, and microorganism lined by granulation tissue and fibrosis.
Okay. So
inside it, we have
go on.
Yes.
What's inside it?
Dead and dying tissue, microorganisms, neutrophils, liquefied tissues. I think.
Yeah. So I think, like we said last time, just keep it simple. A cavity, it's an abscess, is a cavity containing pus. That's it.
Yes.
Cavity
Yes.
containing pus. That's it, right? What's inside it? You said, this is the way I like to define it. It's just cavity containing pus. What's inside it? It's a dead tissue and dead cells, dead bacteria, surrounded by macrophages, polymorphonucleosides, and fibroblast on the outer surface, and telangiectasia. These are what surrounds an abscess. All right. So necrotic tissue, layer of present neutrophils, and zone of telangiectasia of dilated blood vessels. Well, how neutrophils migrate to the site of inflammation?
How neutrophils migrate? There is they home into the site of inflammation due to the chemokines. First, there is blood vessels. Inside the blood vessel, the neutrophils adhere to the vessel wall. Then there is first there is rolling, then adhesion to the walls of the blood vessels, then transmigration. I think it's something like that.
Yeah.
Yes,
yeah,
rolling.
well done. Yeah, you got it all. Well done. I'm not going to even repeat it. So rolling, adhesion, transmigration, and chemotaxis. What are the blood tests to identify inflammation?
Erythrocyte sedimentation, ESR, erythrocyte sedimentation rate, CRP level, WBC counts in the blood, neutrophil counts.
Yeah, that's it.
I think so.
So FBC, you have white blood cells, neutrophils, and acute phase reactant CRP and ESR. What is a carcinoid tumor?
Carcinoid tumor is a neuroendocrine tumor that can arise from a variety of organs. mostly secrete serotonin and 5 HIAA products, leading to a constellation of symptoms.
Yeah, excellent. So carcinoid tumor, a slow-growing tumor of neuroendocrine origin, they usually arise. What is the cell of origin for them?
Cell of origin. Functional cell of origin, serotonin producing cells.
So it's enterochromaffin cells, which are called
Yes.
flush Tisky cells. Flush Tisky cells. Okay.
Cells.
Where is it most commonly found? The common sites. for it?
Most commonly found in the GIT, in the small bowel. Small bowel.
So
That
yeah,
is
most commonly, you need to mention, first thing you need to mention is terminal ileum and appendix.
Yes.
But can be found anywhere in the gut. And 2 can be found in the liver. 3 can be found in the lung as well. Right? These are the main reasons, the main sites that I need to mention. So 1 is appendix and terminal ileum. These are the commonest sites of all time. Anywhere in the gut, and then lung and liver. Okay. What does it release? You mentioned serotonin and the 5-HIAA products. What else?
Vasointestinal peptide.
Yeah. So basically, it secretes bradykinin, tachykinin, serotonin, prostaglandin, substance P, and histamine. What is the clinical presentation of this tumor?
Patient will present with flushing, bloating, sweating, weight loss.
No. So the question is asking you about the tumor and not the carcinoid syndrome. There is a big difference between them. All right?
Yes, it can present with a lump in the abdomen. It can present as constipation. It can present like obstruction, interception, bleeding per rectum.
Yeah. Excellent. So all of this, in addition to, it might present with carcinoid syndrome if it arises from the liver and or arises from the lung. But usually, if it does arise from the bowel and you have a healthy liver, you will not have carcinoid syndrome. And obviously, carcinoid syndrome is asthma-like symptoms and diarrhea and flushing. This triad. Okay.
Yes.
Asthma-like symptoms, diarrhea, and flushing. Okay. The diarrhea, flushing, and asthma-like symptoms, and even they can get with tricuspid regurg and the wheeze and asthma-like symptoms and the bronchial constriction. Okay. So how does carcinoid tumor spread?
Carcinoid syndrome tumor spreads through the blood vessels, most commonly metastasizing to the liver and the lungs.
Okay. So I think that the next question is you answer the next question, which is the most common sites of this in the liver. But the question is asking you, how does it spread? They're asking about the pathology of being spread somewhere else. So basically, there is something called production of something called beta-catenin, which this enables the tumor cell to adhere and promote the metastasis to different things. So the main thing you need to mention is beta-catenin. Okay. Well, why does a person with heavy metastasis to the liver will have more symptoms of the carcinoid syndrome than the primary tumor, which arises from the appendix?
Because when the liver is functioning normally, the 5-HIAA products are metabolized by the liver into inactive products, so it does not cause carcinoid syndrome. But after metastasis, it can lead, the liver is inefficient in clearing these products, so they are released in the blood in larger quantity and thus cause carcinoid syndrome.
Yeah, excellent. So basically, the way I would like, I mean, you answered it very, very well. I'm not saying that you didn't answer, you answered it very well. But the way I would like to say it, so the gut venous drainage is through the portal vein, which will go to the liver. So any products that will be secreted from the carcinoid tumor will be metabolized and broken down in the liver into inactive ingredients. Okay. But when they have the tumor in the liver, there will be the secretions will be very large amount of secretions, and all of it will not be degraded, and they might jump into the circulation and decrease the symptoms. Okay. Next question: how to diagnose carcinoid tumor?
Yes, diagnosis can be based on radiological investigations, that is ultrasound, CT scan, and isotope scanning, that MIBG scanning. It can be looking for serotonin products in the blood, and in the urine we can look for 5-HIAA products. I think.
So yeah, like I said,
Yes.
the way I would like to classify blood test, imaging, and intervention. All right. So
Okay.
blood test, you do have the chromogranin A and 5-HIAA and immunohistochemistry, which is staining positive for chromogranin B. Imaging, many imaging. You have the CT, the MRI, even the somatosensory, the scintigraphy, and the nuclear medicine as well. Intervention, you're doing laparoscopy or bronchoscopy or endoscopy to find the tumor and send it for biopsy. All right?
Yes.
Okay. So in this patient, he has an appendicular mass, and we saw that we're suspecting that he might be having carcinoid tumor. What do you think the management should be? You're currently intraoperatively, and you find that he has a big mass that's extending to the cecum. What will you do?
If the tumor is less than 2 centimeter, we will go for appendectomy, and if it is more than 2 centimeter, we'll go for right hemicolectomy.
Yeah. So the tumor
with
here. So look at that. I'm sorry. This is centimeter, not millimeter. All right.
okay.
So that's the importance of remembering the scenario. Okay. So they expect. I think I would be expecting you to say the tumor is 6 centimeter. So I will go for right hemicolectomy. Okay.
Yes.
Yeah. So that's very important to try to remember the stem that you have. Okay. Great. But yeah, well done. I think we've done the abscess. Otherwise, I could have asked you the questions in the abscess. But let me ask you a few questions from the abscess, really. Can you define what is a sinus?
Sinus is a blind ending tract lined by granulation tissue.
Perfect. Perfect. What is a fistula?
Fistula is an abnormal communication between two epithelial or endothelial surfaces.
Well done. And this is the difference between them. That's a blind end thing with granulation tissue. So that's a sinus, and this is a fistula connection between two things. What is a stoma?
Stoma is an artificially made opening of a hollow organ.
Okay. Excellent. What is cellulitis?
Cellulitis is superficially spreading infection and inflammation of the skin and the subcutaneous tissues.
100%. Yeah, well done. I like that. Those are the 4 definitions that you can confuse them. Okay. Thank you very much for your participation. I think we can go to the next one.
Thank you.
Thank you. Who's next? Right. So I think we can restart again by Sonia if you wanna participate again.
Okay, sir.
Yep. So yeah, let's start with that. You have a 57 male patient coming with dark, painful toe. He's a worker and heavy smoker and denies any history of trauma. Can you tell me about the types of cell death?
Yes, type of there will be apoptosis and necrosis. There are 2 types of cell deaths.
Yeah, so necrosis and apoptosis. Okay, we'll have loads of questions about both of them. The morphological hallmark of cell death, to be honest, that's not really a question. I just like added it to get some basic understanding. So basically, we have something called apoptosis and necrosis. So apoptosis is a programmed cell death. It happens and your body knows about it. But necrosis, it's an accidental death of the cells. Okay? So the hallmark of any cell death whether it's an apoptosis or necrosis. It starts from the nucleus, okay? The nucleus will start to shrink in size. And after shrinking, it will start to break down. And after breakdown, further breaking down into smaller pieces, okay? So this is the main thing differentiation here. So you have something called pycnosis, which is shrinking, karyorrhexis, which is breaking down, and karyolysis, which is further breaking down. Okay. Well, the main difference between apoptosis and necrosis. So apoptosis is programmed cell death. This is accidental. The other thing is, because this is accidental, it will be associated with acute inflammation. But apoptosis does not have any inflammation. Look at the cell at the end. So this one, the whole cell's rupture. Okay. And it has secondary inflammation. But here you have phagocytic cells will start to engulf it and just absorb it. Okay, so that is the main difference between both of them. Here there is acute inflammation, and there is no acute inflammation. Sorry, this is not really needed, just to understand some basics of the coming definitions. Can you define necrosis to me now?
Yes, sir. Necrosis is defined as an pathological tissue death in live organisms, followed by accompanied by inflammation.
Yeah. So again, so it's a death of larger group of cells, followed by acute inflammation, and it's due to underlying pathological process. It's never physiological. All right. So what is the pathogenesis of necrosis?
There will be severe or prolonged ischemia, which will cause swelling of the tissue, and there will be swelling of mitochondria, and in mitochondria there will be influx of calcium, which will cause cell release of lysosomes and rupture of lysosomes and plasma membrane, and there will be cytochrome C released from mitochondria, which will cause death of cell.
Yeah. The main thing is starts by severe and prolonged ischemia, leading to the swelling of the mitochondria, calcium influx, rupture of lysosomes, and death by necrosis and release of cytochrome. Can you tell me about some of the types of necrosis?
Actually, I don't remember types.
Yeah, can you? I mean, I'm sure that you know some of them at
Necroptosis.
least. So we're talking here about man with a gangrene. So gangrene, no, apoptosis is not necrosis. That kills it. So apoptosis is
Yes, I
completely.
remember now. Those coagulative necrosis, caseous necrosis, gangrenous, and one more. I am not able to recall that.
That's fine.
Fibrinoid necrosis.
It's not just one more. You have big list of coagulative, liquefactive, gangrenous necrosis, caseous necrosis, fat necrosis, saponification, and fibrinoid necrosis. Okay, so you really need just to remember the names, but the pathology for each one, you have coagulative necrosis. It's wedge-shaped and usually happen in the lung. Liquefactive necrosis, liquefied tissue. It happens mainly with specifically the pancreatitis, mainly with the surrounding tissue. Gangrenous, it could be, as you see here, this is definitely bad gangrene that you can see here, and it could be wet gangrene or dry gangrene. This looks like wet gangrene. You have caseous necrosis, and it's often definable in terms with TB and fungal tissue. Fat necrosis with the breast trauma specifically. Saponification with the surrounding fat of the acute pancreatitis, and also the dystrophic calcification. Fibrinoid necrosis, it happens in the wall of the blood vessel, specifically in case of hypertension and malignant hypertension. So we're done with necrosis. We define necrosis, we know the types, and we know how does it happen. All right. So can you define apoptosis?
Yes, apoptosis is a process of programmed cell death.
Yeah, that's it.
Which occurs by activation of an enzyme cascade, and it is an energy dependent pathway.
Yeah. So I think, to be honest, I would just stop here. It's a programmed cell death that is physiological and not pathological. All right. It's not followed by acute inflammation and lead to endometrial shedding during menstrual cycle is an example of that. All right, so menstruation is an example of apoptosis. What is the difference between necrosis and apoptosis?
There is a full necrosis is a is not planned. Apoptosis is fully planned by cell, and apoptosis is energy dependent. Necrosis is energy independent. Apoptosis is physiological. Necrosis is pathological, and there will be plasma membrane remains intact in apoptosis, and it is broken in necrosis. And nucleus fragmentation is in necrosis.
Yeah. So yeah, I think what you said is absolutely right. But I think here we're going a little bit down into the pathology itself. So you have in necrosis, you have enlarged cells, and the karyopyknosis, which we mentioned early, the shrinkage of the nucleus. On the other side, you have fragmentation of the nucleus into nucleosomes. All right. You have here disrupted plasma membrane, just intact membrane was altered the structure, especially orientation of lipid to sort of increase the movement of the nucleus to the outside and also the action of macrophages. Here you have digested cellular content. All the cellular content here are intact, and I mentioned one is pathological, one is physiological. Can you define gangrene to me?
Gangrene is a type of necrosis in which there is insufficient blood supply to the organ or the region.
Yep. So that is gangrene type of necrosis, decreased blood supply. Can you what are the differences between dry and wet gangrene?
In dry gangrene, mostly in limbs, wet gangrene in bowel, and on macroscopy in dry gangrene, organ will be dry, shrunken and black, and in wet gangrene, organ will be moist and rotten, swollen and black. And prognosis of dry gangrene is better, wet gangrene is poor, and there will be numerous bacteria in wet